I'm Dr. Heather Rupe. On today's episode of Health Talks from the Inside Out, we're talking all about obstetrics and gynecology.
Dr. Heather Rupe, thank you for joining me on the podcast today.
You're welcome.
So you are one of our OBGYNs and also our chief of staff. We're going to get into the chief of staff in a minute, but I want to learn first, what drew you to medicine?
Well, when I was 12 years old, our family moved to Central Africa, and my parents did mission work there.
Okay.
And while I was there, I volunteered in a really small clinic that did essentially help take care of tropical ulcers for mainly children. And so I volunteered in that clinic honestly because I was bored.
Yeah.
But
How
I
old
got
were you?
12.
12.
And so I was fascinated by the process, and we would document how these wounds got better, and it really just kind of planted the seed for interest in medicine. And ironically, I mean, thinking back, I was basically a 12-year-old helping run a wound care clinic.
Right. What an interesting medical school application you must have had.
Yeah.
I'm sure that's a story that they don't hear often.
Yes, it was very interesting. And then over the years, just the interest kind of grew as I got older.
Yeah. So once you were in med school, I know that y'all kind of go through all the different specialties and you rotate in and out to see what you might be drawn to. Why OB/GYN?
Well, ironically, when I went into med school, there was two things I said that I would absolutely never do. And one was pediatrics and the other was OB/GYN.
Oh my goodness. Okay. Why? What are you thinking?
The average person doesn't really know what OB/GYN does. And my only experience with OB/GYN was getting pap smears. And why would you want to do pap smears all day? That doesn't sound like a very fun job.
Right.
But during, I think it's like my second or third rotation, I worked with an internal medicine doctor, and I was planning to do family medicine.
Okay.
And he spent the month with me, and at the end of my rotation, when he did my review, he's like, "You did a really good job." He goes, "But I think you should reevaluate and consider OB/GYN as a career." So I moved my OB rotation up, and the next month I rotated with a private practice doctor whose practice is very similar to what I currently do.
Right.
And I just loved it. I loved the variety. And on my last day of that rotation, when I had to go home, I actually cried the whole way home because I was so sad that it was over. And I knew that's really just what I loved.
So how cool that doctor you were working with saw something in you that you didn't even know.
Absolutely.
And he recommended that. That's great. Yeah. Okay, so let's talk a little bit about what all does OB/GYN entail.
Well, it's more than pap smears.
Okay, yes.
So in addition to that, all kinds of GYN problems. We treat endometriosis, PCOS, chronic pelvic pain. We do a lot of surgeries. I do a lot of robotic surgeries, which is really interesting, and also scratches that itch I talked about, when I did the wound care when I was 12, how you just watch things get better. Yeah. Surgery is great because somebody has a problem. They have a cyst, they have a fibroid, they have a polyp. You take it out, they get better. It's very fulfilling. Also, of course, obstetrics, everything from preconceptual counseling through deliveries. We do C-sections, we do postpartum depression, postpartum care, IUDs, kind of the whole gamut. So there's such a wide variety of things that we get to do.
I love that. Okay, let's start with the OB side, the obstetric side. And I'm curious, do you know how many babies you've delivered? And if so, what is that number?
Around 4,000.
Oh my word. Okay, 4,000. In how many years?
24 years. I did 4 years of residency, and then I've been in practice here. Well, actually, almost 21 years that I've been here at Williamson. So,
oh my goodness.
And a couple last nights. That's why I've got some bags under my eyes.
Oh my goodness. Okay, a couple last night. So do you remember the very first one? And if so, can you tell us about it?
My first delivery was in Woodward, Oklahoma, which is in the panhandle of Oklahoma, at this tiny little hospital. And I was working with this really great family practice doctor who also did deliveries. And he knew that I wanted to do OB at that point. And so I've been waiting for somebody to go into labor for weeks. And finally somebody was there and they were in labor, and I got to deliver the baby, and it was just so magical. I still get a little teary thinking about that.
And being a student doctor, delivering, how does that conversation go with the mom, I wonder?
There's a whole protocol. And literally the doctor is has their hands over yours. I mean, you always get consent. But even now, we'll have sometimes the dads that want to help deliver their babies, their own babies. And so it's kind of the same thing where we let the dads, we kind of put our hands on top of the dads and kind of guide their hands as they deliver their babies and hand it to their wives. So we do that sometimes. It's kind of the same concept. Yeah.
Speaking of the dads, does a moment stick out where a dad or maybe a family member there in the room has just said something hilarious or off the wall or have questions?
Oh, there are so many. Many I can't repeat. Some of my funny stories that I can repeat. This is this happened quite a while ago, but this lady, and people are always like, well, when's my favorite question that I can't answer is like, well, when do you think my baby's going to come? Because everybody thinks their baby's going to come on their due date. And sadly,
and very rarely probably does it come on the due date.
Less than 3% do the babies come on the due date.
Wow,
so,
okay.
They do not check my Google Calendar as to when they should come either. So they come whenever they want to come. So this sweet patient is her first baby. And so I think she went like a week over, and then she was in labor for like 3 days, and then bless her, she'd been pushing for like hours, and she was doing great. It's just it's called labor. It's a hard process.
Right.
So she'd been pushing for a long time, and then her husband was like so calm, like in general, he's just like this really laid back, and all of a sudden he starts to get really aggressive with his like, push this baby, like encouraging her to push the baby out. Like, no, push harder, and like really like aggressive. And I'm like, this seems really out of character.
Right.
And so she finally delivers, and he sighs with relief, and he pulls out this beautiful ring. He had bought her a ring with a birthstone, but the month was about to change. It was like 11:50, and so because she had went so far, she had been due like the 20th, and so by the time she went into labor and was labor for days, so it was like almost a different month. And so you could see him like looking at the clock, being like, this birthstone is about to not be the right one in a couple hours. That was one of my funny stories. I always think of that when someone's like not coming when they're supposed to, when the babies are coming.
Right, you knew something was going on. The stress and anxiety of all that planning. Oh my goodness. So 4,000 deliveries later, is each one still special?
It is still a miracle every time. I mean, even the delivery I did last night, I watched the little tear come down the dad's eye when he saw his baby for the first time. And it's still just magical. And
Each and every time.
Each and every time. I mean, there are some hard times, obviously. It's a hard job. But seeing the joy on the parents' faces when they see their babies for the first time is still magical.
Oh, I love that. I know. Takes me back to when I had mine. And obviously we've been talking about delivery, catching, you've been doing this, catching the babies, but you also perform the C-sections, right?
So obstetricians and gynecologists are trained to do C-sections. Now, you have family practice doctors who do deliveries who don't always do C-sections.
Okay.
We only have OBGYNs here at Williamson, and all of the OBGYNs are highly trained in C-sections. Although I will point out we have one, if not the lowest C-section rate in the entire region, and we work very hard to keep our C-section rate at a safely low number.
Yeah, that's great. Okay, so you mentioned all the OBs at Williamson Medical Center. So let's talk about that, because we actually do have 2 OB groups that deliver at our hospital. Can you talk a little bit about that?
Yep, I'm part of Williams Cooper Franklin, and then there's a separate group called Vanderbilt Franklin Women's Center. We all work very well together. There's 5 delivering doctors in each group, and both are extremely high quality groups that we work together on different quality improvement projects, policies and procedures. We cover for each other for emergencies when needed, if we can't get hold of any of our partners. But high quality docs in both groups. Cannot say anything but good things about all the OBGYNs at Williamson.
And all female, right?
Yep, all female.
In both groups, all female.
Yeah.
And I do love how y'all work so closely together, like you said, just from planning and processes and making sure that we're always continually improving and then covering for each other.
We do. And we don't cover call for each other necessarily. We have our own separate call groups, but in true emergency situations, they know that they can call us, that we know we can call them if we need a second backup hand with anything.
Yeah, that's great. Okay, so let's keep going with kind of the OB unit here at Williamson Medical Center. So we are routinely getting recognition and awards for our overall women's services, but often for perinatal OB. We have a few that we've just been told about that I can't talk about yet, but there's a few more coming down the pike specifically related. to OB that we're going to be excited to talk about. But can you talk about the services that we offer here from OB to NICU? Let's also talk about maternal fetal medicine, because I know that's an important service that we can offer some of your patients.
So we have a really unique labor and delivery unit. Our nurses are so amazing. We are able to do really high-risk deliveries, but also we do a lot of low-risk deliveries. And we're there for when those low-risk deliveries turn into high-risk deliveries, because you never know when that's going to happen. Having the NICU here is such a bonus because we have in-house neonatal nurse practitioners. So anytime there's an emergency with a baby or an emergency delivery, they're there. We have in-house anesthesia for emergencies, and having that local NICU so patients don't have to drive all the way to Nashville when their babies are in the NICU. I mean, that's like 2 extra hours a day that they get to spend with their baby. So for patients who want a low intervention birth and prefer a more natural experience, we do have a labor tub.
Okay.
We have a protocol for patients who prefer to want to move around in labor or labor in different positions. We also offer VBACs, vaginal birth after C-section, for either 1 or 2 C-sections. And again, like I mentioned, we're there when those, hopefully everything goes smoothly and we have those nice unmedicated, uncomplicated deliveries. But if not, then we have the team there to handle the emergencies.
Yeah.
On the other hand, when we have patients who come in who are truly high risk or who do want that epidural the minute they walk in the door, that's okay too. Yeah. And we have the anesthesia available, we have the teams available, and I just have to say again, what high quality nursing staff and support staff we have. I can't tell you the number of times I hear compliments on our nurses after delivery and what a difference they made in that process with the staff and how hard they work. I mentioned our low C-section rate. And a lot of that's the nurses. They get in there, I call it the labor yoga. When someone's in labor and they have an epidural, they have all these birthing balls or labor balls, and they get them in all these different positions to let the baby come down through the birth canal to help facilitate that vaginal birth. And they really, really care and really go the extra mile for their patients.
They do. People love having their babies here. And you're right, it's because of the whole team. So for any of our listeners who might not have been here in the past year and a half or so, we have recently expanded and renovated the OB and NICU unit. Is absolutely beautiful. Can you talk a little bit about it?
I love our new unit. And I mentioned we always have had the quality of care. We've always had these great nurses, and now we have a beautiful, beautiful unit that goes along with that. We have 16 labor rooms. Okay. We have 3 operating rooms for C-sections, so we always have a backup. We have 17 postpartum rooms, and these rooms are absolutely gorgeous. They're all private bathrooms, private showers. Plenty of space for visitors, a really ergonomic setup for the nurses, in addition to our 9 NICU bays, which are all private, so that the parents can be in there individually with their babies. And so it's just so nice to have this beautiful space.
Yeah. And one of the things I love most about the NICU also is there's a family sleeping room. Is that what I say? A room in. So the night before a family is anticipated to take their baby home, they get to stay in the room all night together to kind of practice being at home.
And they're right there by the NICU team. So
right. In case something goes wrong.
In case they're wrong, and they have them to ask questions. Yeah.
Right. Yeah, that's really special. And just to make sure people heard, so the labor rooms are different from the postpartum.
Correct.
So where you begin and you're laboring and then have the baby, shortly after that, you'll be moved to a different room.
Yes, and the postpartum rooms are very large, and they're quieter. So the postpartum wing is much quieter. So not that the labor room's loud, but labor can be a little loud. So you're transferred to a different part of the same floor. It's all very secure. No one can come in or out without checking with security or having a special badge, but that's a separate part of the unit.
Yeah. What I think I heard you say is our team, y'all work really hard with each mom, each family, and you really customize care according to their birth plan.
Yes. So my job is to keep that mom and baby healthy, and however they want that baby to come out is up to them. So some patients want that epidural the minute they walk in the room, and some patients want things as natural as possible. Now we do things within it. We want to keep everybody safe,
right?
But yes, we very much try to honor the patient's wishes with their labor requests as much as we safely can.
Yeah, and just to make sure people understand the VBAC.
Yeah.
So that is just because a mom might have had a C-section with her first child or her second child, doesn't mean that she has to have the next child that way. In some cases.
In some cases,
we
yes.
can try.
Yes, there's guidelines for who's appropriate VBAC candidate, but we definitely do a lot of VBACs. We do some natural VBACs. We have a Bluetooth monitor, so patients who want to kind of move around in labor, and we do watch those because they are a little bit more high risk. We watch those more carefully, but for appropriate candidates, we do VBACs quite frequently.
So for a mom who might have had a C-section in the past, they can at least ask
Yes.
with their next pregnancy.
Absolutely, yes. So absolutely, we go through the risk and benefits of that. And for a lot of patients, that is a good option for them. Yeah.
So we kind of jumped in at the end of a pregnancy process because that's the fun part. We talked about delivering the babies and our beautiful unit and birth plans and all of that. But let's back up a little bit and begin with maybe prenatal care or what the office experience looks like throughout pregnancy.
Well, in an ideal world, I would love to actually see patients for preconceptual counseling visits. So before they even get pregnant, sitting down with them to go over, hey, let's talk about how to get your body in the best possible shape so we can have the healthiest pregnancy possible. So usually if we can, a lot of times we'll do that at their annual visit, but some patients, especially if they do have underlying medical conditions like high blood pressure, or PCOS, or diabetes, then we may need to even do a special visit, or we can utilize our excellent maternal fetal medicine team, high-risk specialist team. If I had a pregnancy billboard for the best healthy pregnancy, it would be take your folic acid. So being on folic acid, at least 400 micrograms a day before pregnancy actually reduces your risk of multiple birth defects. So a lot of patients will be like, oh, I'm not sure which prenatal vitamin to take. Maybe I'll talk to my doctor once I get pregnant and ask them. I really would love you to start your prenatal vitamin about 3 to 4 months before you get pregnant, and that's going to have the best possible outcomes. And again, it needs to have the folic acid, at least 400 micrograms, although a lot of them will have more than that. And you essentially can't take too much folic acid, but we want at least 400 micrograms a day. We see you in the office pretty early, between 6 to 8 weeks. And then monthly till the 3rd trimester, and then more frequently the 3rd trimester, and then weekly those last few weeks of the pregnancy. And then we there for delivery, and then the whole postpartum period. So postpartum is super important. There's a lot of complications that can happen postpartum.
Like what?
High blood pressure. We think of high blood pressure as going away with delivery, but it actually can increase from the first 2 weeks postpartum. Postpartum depression. That's a big passion of mine. We do have really high rates of maternal mortality in the United States. And honestly, if you look at the data, one of the biggest risk factors for that is postpartum depression. We think about hemorrhage, we think about different other preeclampsia, different other issues that could cause, and stroke is causing maternal mortality. But postpartum depression is one of the highest risk factors for maternal mortality. So really addressing and getting aggressive with postpartum depression is also one of our passions.
So the care doesn't stop for several weeks after they deliver. They're, coming to see you,
coming to see us, checking in, make sure that they're doing okay, both physically, emotionally, and everything's going well.
Let's continue just for a minute, because postpartum depression is so important, and it's something that maybe in the past we haven't talked about as much as we should. Just for any listeners who might be listening, who might think that they're dealing with that, but are afraid to speak up or feel some sort of shame around that or whatever, just let's talk to them a minute about how important that is to reach out and get help.
So about 70% of women during their first 2 weeks postpartum are going to feel a little bit emotional. It takes 2 weeks for your hormones to go back to normal after delivery. Then you hit about that 2 week mark, your hormones come down, you start to feel a little bit more like yourself. Still maybe a little anxious about that new baby, but overall that gut feeling is one of joy. If you hit that 2 to 3 week mark and you are feeling empty inside, if you're continuing to have crying spells, if you're having thoughts of needing to escape, that's kind of a red flag that you might be experiencing postpartum depression. And we know now, we've got more and more data on postpartum depression, that we know it's a big part of it's a hormonal trigger. So I always tell patients, if your blood pressure was elevated, you would take your blood pressure medicine. If you have postpartum depression, if you're having these thoughts that you can't control, if you're crying, if you're not being able to take care of yourself or your baby, that is a physical condition, and we have treatments for it. And we even have now, there's a newer medicine that treats the root cause. It actually treats the hormonal cause of the postpartum depression, and it's not the traditional depression medicine. And I found that to be a game changer for a lot of my patients. So I just really encourage patients to reach out to their provider. And if your provider is not listening to you, then find someone who will, because it's such an important thing. And at the end of the day, this should be, the postpartum time is hard, but it should be something you look back on with absolute joy, one of the most beautiful times of your life of enjoying that sweet baby. It shouldn't be something that you have to push through and endure. It should be a beautiful, beautiful time for you and your family.
So you mentioned our maternal fetal medicine practice, Dr. Michael DeRoche and Dr. Chelsea Clinton. Can you talk a little bit more about the services they offer, the benefit for the patients, just the overall care they provide?
Well, first off, they are both such top-notch quality physicians and people. I'm so excited that we have them on our team. So I went to college for 4 years, medical school for 4 years, and then I did an additional 4 years of OB/GYN training. Maternal fetal medicine goes another 3 years where they just focus on learning about high-risk pregnancies. So they learn high-risk ultrasounds, they learn how to take care of patients with the most complicated conditions, take care of a lot of issues with twins, a lot of issues with people with underlying medical conditions. And so they are kind of our consultants. So in our patients who do have these more complicated conditions for either the mom or the baby, they can see the high-risk specialist in addition to us. We do the delivery still, but they're there to help guide us on when to deliver, what medicines to treat, how to best get this baby the care that it needs. And they can see patients in their office here in the tower, and they also have privileges at the hospital for patients who do need inpatient high-risk care. So I'm just thrilled that we have them on our team and the benefit that gives our patients, and our ability to keep some of those higher risk patients here. So again, that they're not having to travel downtown, and they're getting that same quality of care right here at Williamson.
Right. And I would like to go ahead and say too, on the williamsonhealth.org website, you can find information to get to your group, the Vanderbilt group, as well as the maternal fetal medicine. So if anybody out there is needing a new doctor, they can go to the website and find all of y'all's contact information. One more plug before we move off of OB. I wanted to say, from a marketing standpoint, the most beloved thing we do on a regular basis is our monthly baby photo shoots. So if anybody listening or watching the podcast isn't following us on social media, give us a follow, because we pick a theme each month. And then we have actually one of our employees who works in our EMS organization. She hand crochets these beautiful outfits, and we do a little monthly photo shoot. We pick one newborn boy, one newborn girl, and we take these beautiful photos. And
they are so cute. We love those.
Yeah,
we love
they're
those.
precious.
Yes.
So we've talked a lot about the obstetrics side. Let's move a little bit more into the gynecology side. So what all does that entail?
So with gynecology, in addition to the annual exams, we also,
very
important. We also treat all manner of GYN problems. So everything from contraception, like doing IUDs and birth control, to treating endometriosis, PCOS, heavy menstrual bleeding, fibroids, cysts. We do a lot of GYN surgery. I personally do a lot of robotic surgery, which I really enjoy and feel like it makes a big difference for the patients. Oh, and let's not forget menopause. We do a lot of perimenopause and menopause. We'll get to that. But all ages and stages.
Okay. Yeah. There's so many different places I want to go right now, but you've mentioned PCOS a few times now. What does that stand for, and what is that?
Oh, polycystic ovarian disease is a condition. It's actually a metabolic condition, so it affects your metabolism. So it's named after the ovaries because people like to blame things on the ovaries, but it's really not PCOS is not the ovaries' fault. It has to do with how your body processes glucose. And so it's kind of almost like a pre-diabetic condition. But in people with PCOS, their elevated insulin levels cause their ovaries not to function normally, which causes them to not have regular periods and difficulty getting pregnant and weight gain and various different issues. So. But it's a common thing that we see and treat.
Right. So let's talk a minute about robotic surgeries. So going through medical school and your residency, learning to become an OB/GYN, I assume hysterectomies and surgeries was part of that. But when did the robotics part enter for you?
For me, so in training, I mainly learned to do laparoscopic hysterectomies. Some people call it the laser hysterectomy, but it's basically where you go through small incisions in the abdomen and use instruments and cameras to do the surgery.
So you're not having to open.
Correct. I have to open
a big.
And sometimes we still have to open people occasionally. But with the advancement of the technology, now we use a robot, specialized camera, and specialized instruments. I mean, I'm still controlling those, but we're able to see things a lot better and to do a lot more complicated cases with that. It's just been advancement. It has probably. When I was in training, it had just came out, but only the specialists were allowed to use the robot. And I've been doing robotics myself for probably about 7 or 8 years.
And just a sidebar for a minute, we are very proud of our robotic capabilities here at Williamson Medical Center in general. I love that we have those capabilities. We're continuing to elevate all the time. And there's different specialties like OBGYN that also get to use the robot.
We all get to share the robot.
Yeah, that's cool. So let's go back and talk about the importance of the annual exam. Why should we as women be coming to see a GYN every year? And at what age does that begin?
Yeah, it's a very good question. So we usually would recommend you follow up with a GYN either for younger patients if they're having a problem, so if they're having heavy painful periods, or if they're sexually active, or age 21, whichever comes first. So we start the first pap smear at age 21, and then we usually continue pap smears to around age 65, sometimes a little bit longer depending on someone's risk factors. At your annual exam, there's a lot of different things that we're looking for. We're screening for breast cancer, we're screening for all those different medical conditions that I mentioned, like endometriosis and cysts and fibroids. We're looking for cervical cancer. We diagnose thyroid disease. We're making sure people are getting their screenings. So making sure that they're getting their mammograms, or encouraging them to get their mammograms, their colonoscopies, their bone densities. And these are all things we want to catch early. So even someone feels healthy and they feel fine, they're like, I feel fine, I don't need anything. But with most GYN issues or cancers, if you get to the point where you're feeling something's off, it might be too late.
Right. Yeah. And did you mention breast exams too? Yeah. Because that's part of the annual.
So we do an annual breast exam just to make sure. You know me, I'm very scheduled person.
Yes.
So a good habit stacking or good scheduling thing is I always tell women they can do their self breast exam the week after their period. So that's when your breasts are least swollen and tender hormonally. And so whenever you put your period products away, that's just a good reminder to go ahead and do your self exam.
Yeah. And if a listener has never had a pap smear before, and maybe they've only seen it represented on TV, I know some people are intimidated or scared by it, but it's not a big deal.
If you're with a provider and you're having pain, let them know. Okay. We have all different sizes of speculums. We have all different types of equipment to make it as comfortable as possible for each patient. So it should not be painful.
And that's a good point. If it is painful, let the doctor know. We're in a vulnerable state as the patient. It's a little bit uncomfortable and embarrassing, but it should not be painful. So speak up if it is.
Yeah. We're really focusing on that both with our group and nationally as gynecologists to try to make all of the women's healthcare experience more comfortable for our patients.
Yeah. Okay, so let's talk about menopause a minute. You mentioned that. I'm so excited because I feel like as a society we're talking about this more than maybe we ever have. But let's talk a little bit about perimenopause, menopause, and why women approaching maybe their 40s, certainly their 50s, need to be looking at things, talking about things. Let's go for it.
I love that we're talking about menopause and perimenopause more. Women are much more open to taking medicines. We have much more options. We have hormonal, non-hormonal options for all the different symptoms, and we have more data. Okay, so the average age of menopause is 52.
Okay,
but that can be plus or minus 5 years.
Okay,
and perimenopause can be plus or minus 5 years. So we can see symptoms as early as early 40s. Some people don't have a single symptom until they're 50. Some people never have a symptom. But essentially, if someone is experiencing hot flashes, night sweats, vaginal dryness, irregular cycles, insomnia, then that's something we can definitely sit down and talk about as far as getting different options for treatment for that. I kind of see your annual exam in your 30s and 40s as your premenopause counseling visit.
Okay.
So get your exercise as much as you can in your 40s, get your screenings, and then as you start to feel those symptoms, if you do start to have hot flashes, night sweats, if they're affecting your quality of life, sit down with your provider and we'll talk through all the different options that we can do for that, because we do have some great options now where you don't have to be miserable.
And so what are some of the treatment options?
Well, what's happening in menopause and perimenopause is your estrogen levels are dropping.
Yeah.
So replacing your estrogen as a patch, a cream, a pill.
Suppositories.
We can do all kinds of stuff. So we can do replacing the estrogen goes a long way for treating symptoms. We can replace someone's testosterone, someone's progesterone. So all those hormones are well, in perimenopause, they're doing a roller coaster, and in menopause, they just go, they drop.
Okay.
So figuring out how to keep those balanced and how to treat those, taking your vitamin D, getting your exercise, getting your sleep. Sleep is so important.
Now, a minute ago when you said 52 is the average age for menopause, is that to be done with it or to begin it?
To be done with it.
To be done with it.
Yeah.
Okay. So how do we know when we're done with it?
So menopause means a year with no periods.
Okay. And then once you quit having the period for a year and you've gone through menopause, do the hormones level back out naturally? What happens on the back
No, they don't
end?
have any.
Oh, they're just done.
They're done because your ovaries are like,
okay.
So your ovaries are like the little engine that could, okay?
Okay.
And they're like, I think I can. And then they spit out a little egg and you get a little burst of hormone and you have a period. Okay. And then they're like, I think I can. And then a couple months later, they give you a little burst of hormone. And that's what kind of the perimenopause is. And then at the very end, they're like, oh, we're done. And
we're
so
done.
They're done.
And it's just over.
They're just over. And so they don't make any more eggs and they're done with the estrogen. Now they still secrete a little bit of testosterone even after menopause, but the estrogen and progesterone are like, they're just done.
Yeah.
They've done their job.
I love that. The little engine that could. That's great. And that'll ovaries. They're trying so hard. Yeah. Okay, so just to make sure everybody knows, what are the most common symptoms again for each of those stages, perimenopause and menopause, and then what might be some little known symptoms that people should still be aware of?
So classic symptoms that are for sure we know associated with low estrogen are hot flashes, night sweats, vaginal dryness, and irregular cycles. Okay, those are for sure.
Right.
Now, we have this whole other subplot of these symptoms that are sometimes hormonal and sometimes just other things, medical conditions, life, stress, all these other things. And those would include fatigue, joint pain, brain fog, decreased libido, weight gain, insomnia.
Okay.
And now some people like to blame everything on the hormones. We can't blame everything, but a lot of things are helpful with them.
Yeah. So before we leave this topic, is there any final thing you wish people knew about gynecology?
I see so many women who live their lives around their period. So what I mean by that is I'll ask them, how are your cycles? And they're like, well, they're really not that bad. There's only one day that I can't leave my house. You know, there's only like 1 or 2 days where I have to reschedule my workouts because I'm bleeding or I'm hurting.
Right.
You know, there's only one day that I max out on my ibuprofen and then I'm back after that. And there are so many different treatments that we have for heavy menstrual bleeding that your life should not revolve around your period. Okay. That's my number one.
Okay.
And number two, sex should not hurt. There's so many women, especially after menopause, who have painful intercourse, and we have so many treatments for that. I'll see women who've suffered with heavy periods for years and years and years, or suffered with painful intercourse for years and years and years, and it's so unnecessary. So there's so many different treatments for this. So if I had a OB billboard, I would say take folic acid, and if I have a GYN billboard, I would say you don't have to live your life around your period. Sex shouldn't hurt.
Wow. Okay, maybe we should put those on the billboards. No, I love how you boiled that down because again, I feel like for years, decades, you know, as women, we just think, well, there's certain things that come with being a woman and we just have to live with it.
Just have to live with it. And we don't. Yeah. We don't have to suck it up.
Yeah.
We are tough, but we can be tough in other ways.
Right. Okay, so let's talk a little bit about your chief of staff role. Okay. And I might add, you're our first female chief of staff. Yeah. Which is very exciting.
Thank you.
Yeah. So how long have you been serving in that role? How long are the terms?
I've been chief of staff for 4 years, and I'll have another 2 years as part of the role.
Okay. And what does that mean? For the layperson, what does chief of staff do? What does that involve?
So chief of staff serves as the head of the medical executive committee. The medical executive committee is made up of the heads of all the different departments. So the surgeon that's the head of the surgery department, the pediatrician that's the head of the pediatrics department. So we meet to make the policies and procedures for the hospital to make sure that everything is following the highest quality of care, make sure all the patients are taken care of, and make sure that we are credentialing and keeping the most high quality physicians on staff. I also serve on the Williamson Health Board of Trustees, so I bring information about how the medical staff is doing to the board and help them make policies and procedures, again, that help make us the best hospital possible.
So I'd like to ask, what makes you most proud of being part of this particular medical staff here?
So our hospital has been recognized nationally for our quality, for our patient safety, for our excellence in multiple different departments. Yeah. And a big reason for that is the quality of physicians we have here at Williamson. Yeah. They are not only excellent clinicians, intelligent, but they are compassionate physicians who really care about our patients. To be the head of the medical staff, to be elected to that position as such a high quality group of physicians is truly humbling. It's truly an honor, and it's a responsibility that I take very, very seriously.
Yeah. And what a benefit it is to all Williamson County residents and our surrounding regions here. You're right. The physicians have the capabilities, they have the skills, the expertise, but they also bring that emotional, compassionate kind of hometown feel to the care they're providing.
Absolutely.
Yeah. Also, a lot of people don't know we have over 900 different providers on our medical staff. And for a health system our size to have that many physicians on staff is just remarkable.
It is remarkable. We have a great breadth of specialties that we're able to offer our patients. Yeah.
So now that you've been practicing medicine for over 2 decades, do you have a particular patient story or a few patient stories that stick in your mind over the years?
One of the harder things that we deal with in obstetrics is miscarriage. Yeah. And sometimes we don't have answers for why they're having losses. I remember a patient who'd had, I think it was 3 or 4 miscarriages, and we'd done all the tests, we'd done all the workup, and we couldn't find a reason. And I remember her saying, I'm just done. I can't go through another heartbreak like this, emotionally heartbreak. And so her partner got a vasectomy. She's like, we're not going to have kids. We're just going to be at peace with where we're at. And about 6 months later, they had the vasectomy failed, and they got pregnant.
Oh my goodness.
And 9 months later, I delivered this healthy baby. Yeah. And I always say that was like the most meant to be. Yeah. Those are the moments that keep you going. Those are the moments you remember that really matter to those patients.
Yeah. So what would you say is the most rewarding part of your job?
Getting to know my patients over the years and seeing them grow and growing together and in this community.
Yeah. Well, and we're so grateful to you, to your partners, to all the physicians here for those relationships that they're making, that connection, and of course the great care they're providing. We are so proud of all of you.
Thank you.
Yeah. Well, thank you for joining me today. I think this has been fantastic. Yeah. And you're right, we could have gone an hour on multiple different topics. We might have to have you back. But I greatly appreciate it.
Thanks for having me. It's been fun.
Yeah.